Wonderful. Welcome. Good afternoon, everyone. Thank you for joining us today for Building Effective Disability Policy in GME, introducing the Disability Policy Toolkit. This is a collaboration of the Docs with Disabilities Initiative and the ACGME, and it was funded by a Macy Catalyst grant. We're very excited to be with you and share this component of the Disability Hub. My name is Morgan Passiment. I am a program director of special projects at the ACGME. As we move forward, just have to say that there's a little bit of a disclaimer here because we are talking about policy. Wanted to make you aware that these materials do not constitute an ACGME developed best practices and do not necessarily reflect the opinions of the ACGME, and they should not be considered necessary or intrinsic to compliance with ACGME requirements. We encourage sponsoring institutions and programs to consult with your own legal counsel before implementing any of the ideas or strategies presented. Just wanted to speak a little bit about why we did this, and that is that clear, accessible, and consistently applied disability policy is essential in advancing inclusion in graduate medical education. While the ACGME Institutional Requirement 49D requires sponsoring institutions to maintain a disability policy, many institutions continue to struggle with developing policies that are not only compliant, but practical, transparent, and meaningful in real educational settings. The Disability Policy Toolkit was created in direct response to institutional requests for clearer guidance on how to build, review, and operationalize disability-related policies. Today, we're going to go over several aspects of the Disability Policy Toolkit, including modeling disability policy language, guidance on policy development process, applying disability policy within the GME program, policy dissemination strategies, disability data collection in GMA, and then we will conclude with a moderated Q&A. We have a highly accomplished group with us today that span GME-focused roles, including a DIO, a program director for GME Wellbeing, an attending, and a research policy leader. While this panel presents the policy toolkit today, the creation of the toolkit was informed by the entire committee, which consisted of representation across a myriad of roles, including residents, program directors, coordinators, and disability resource professionals. Briefly, today's panelists are Drs. Jessica Bienstock, Maggie Salinger, Kelly Shaw, and Lisa Meeks. We'll get started with Dr. Salinger.
Hi, everyone. I'm Maggie Salinger, and I'm an internist and researcher at Brown, and I self-identify as having a disability. But that wasn't always the case for me. So as a medical student, when I was applying to residency, I remember having concerns about my autoimmune conditions that at the time I didn't consider disabilities, but I also didn't know anything about accommodations. So I almost chose not to apply to residency. I remember it was really, I did apply anyway, but I remember it was really scary to make a rank list without knowing about how I could safeguard my own health during my training. And so for next slide, please. So when I was going through the onboarding process for residency, I was advised not to work 30-hour call. So I received a scheduling accommodation that changed those rotations with a long call schedule to a day-night shift instead. And additional accommodations were offered, but I declined them because of my own sort of internalized ableism and concerns that I had about not wanting to burden my colleagues. So one of the things that struck me about my disability identity was that for me, it was something that emerged, not from a change in my diagnoses or symptoms, but rather, from a change in my work structure and institutional processes. So I knew that the stressful parts of my story were not unique. And I was inspired to design a qualitative study that interviewed internal medicine program directors across the country to learn about their experiences of recruiting and accommodating residents with disabilities. And insights from these interviews helped inspire the Disability Policy Toolkit that we're here to discuss today. So, an overarching theme from this study was that information asymmetry was contributing to a misalignment in needs between program leaders and residents with disabilities. So, for example, program leaders wanted to know about a disability as early as possible. This would give them time to consult experts, change schedules, or make other arrangements for accommodations. But they also understood that a resident or applicant might opt to delay disclosure because of stigma, bias, or fear of discrimination. So this theme of information asymmetry also came into play when trying to define accommodation needs or options. So a challenge for program directors was that they had to work with limited information about the underlying conditions they were being asked to accommodate. And this is because of things like fair hiring practices, HIPAA, or just a desire to maintain professional boundaries and not, play doctor for the residents. But meanwhile, program leaders also understood that a resident might be an expert in their own disability, but as trainees, they still lack the requisite expertise in like GME protocols or programmatic possibilities and resources. And, this was especially true if you're an incoming intern who's like never been a doctor before. So, program leaders understood that learners, couldn't be in charge of designing their own accommodations themselves. I think, fortunately from these interview discussions, program directors identified several opportunities to disrupt this harmful cycle of information asymmetry, to better align needs for all parties. And Dr. Meeks then rallied a team to help answer their calls for improvement.
So in 2019, the ACGME introduced an institutional requirement mandating disability policies that outline disclosure and accommodation processes. The ACGME said that in Institutional Requirement Policy 4.9.d, that accommodations for disabilities, the sponsoring institution must have a written policy regarding accommodation, which would apply to residents with disabilities. This policy need not be GME specific.
Thanks so much. And while the accreditation requirement, of course, marked an important milestone for disability inclusion in GME, I know our team was especially excited. Our research the following year showed that implementation was highly variable. So in 2020, our team conducted a review of disability policies using the largest sponsoring institutions in the United States, the 50 largest. We thought that would capture the most learners. And what we found was concerning. While approximately 65% of institutions technically maintained a policy, these policies often failed to provide meaningful guidance for residents that were attempting to navigate or disclose their disability or engage in an accommodation request. So more recently, this study has been updated and will be coming to the literature soon by my colleague, Dr. Zoe Sheets, and her colleagues. And they're doing an updated version of this. Unfortunately, they found even lower levels of compliance. And yes, we checked those numbers several times because we thought, how could that be possible? But even lower levels of compliance. So taken together, these findings really suggest that institutions, while some of them may have a policy on paper, some of those policies are not functioning as effective tools, and many of the institutions remain policy deficient. So we really need to move towards better policies. And yes, thank you so much. So The 2020 study revealed a lot of gaps, and this is something that really helped us and informed this policy toolkit. In that study, we looked at whether or not policies had clear instructions, and unfortunately, many of them lacked this. Residents could not, for example, determine how to initiate a request or what documentation was required, or even how long the process would take. It was really a black box, the policies that were there. Other policies failed to identify any specific contact person. They would just have a generic email. And that brings up, of course, a lot of fear around who's going to have access to the information that you're providing. Some policies require disclosure of disability to direct supervisors or program leadership as part of the accommodations process. And national professional organizations and researchers have cautioned against this approach due to the inherent conflicts of interest that emerge. And let's not forget the power dynamics present in training environments between an intern and their program director. And then finally, residents consistently report, and what we saw confirm that disability policies were really difficult to locate. Even when they existed, they were often buried on institutional websites, written in very legalistic language, or disconnected from GME specific context. And so, overall, this really left people wanting. The policies that are intended to promote disability access actually became an additional barrier for many trainees. And because of the way they were set up, it really discouraged disclosure and limited the use of accommodation.
So the toolkit was designed to help move institutions beyond minimal compliance and towards policies that are usable, transparent, and responsive to real-world needs. It provides a detailed framework for accommodation requests and examples of communication protocols that clarify how accommodation information should be managed and shared at a program level, balancing privacy with operational feasibility. In addition, the toolkit outlines how an institution could structure grievance and appeals processes so as to ensure that residents have structured pathways to raise concerns. It also includes guidance on documentation and privacy to protect sensitive information. The goal is to give institutions concrete tools that they can adapt to their institutional needs. Dr. Salinger's paper in JGME highlighted a deficit in understanding disability inclusion at the GME level and a desire to have concrete assistance in navigating this area for GME learners. The Disability Policy Toolkit is, in part, a response to this call for more guidance. Good. Thanks. When developing a disability policy, the first step is to be clear about the goal. What issue are you trying to address and for whom? Once that's established, in this case, for whom is about trainees and employees with disabilities, and the issue you're trying to address is the need for clear direction in how to request and receive accommodations. The next most important move is to bring the right people to the table. In GME, that means engaging the administrators and program leaders who will implement the policy, and just as importantly, the learners who will rely on it. Learners with lived experience of disability can offer critical insights into real barriers and often help identify what will work in real practice. If you know individuals with lived experience, invite them directly. If not, an open call signals institutional commitment and helps broaden participation. When lived experience isn't available within an institution, collaborating across institutions is also a meaningful alternative. Finally, once a policy is complete, acknowledgement matters. Contributors should be recognized through authorship or acknowledgement while also protecting privacy. It's appropriate to note that lived experience informed the policy without disclosing disability identities. In this toolkit, we've broken down the policy into actionable sections. And with that, I'll turn it over to Kelly.
And now let's get to the meat of the policy guidance. We'll briefly review each section, but just note all of this information is available to you on the Hub website in downloadable format, so you don't have to be furiously taking notes. So what are the key elements that should be considered when you're developing or reviewing guidance for applying a disability policy? Good question. First, there needs to be a clear, what we call process for disclosure and self-identification of having a disability. A detailed process outline which clarifies how to disclose and ultimately request accommodations. Who's that going to, including contact information for the responsible department and individuals who support this process. In sensitive situations like these, it's so important that we know who is going to be privy to our personal health information and that we're given some reassurance that this information is going to be kept private. So, the process for accommodation requests starts by setting up really clear expectations from the start. That's going to be incredibly helpful. That starts with a comprehensive description of the process, what the resident will be responsible for doing or providing. And as with the process for disability disclosure, the form to request the accommodation should give explicit information about the responsible office or the person who is going to be reviewing those accommodation requests. It's also important to make sure and clarify how this is what we call an interactive process, which means this is likely going to require multiple back and forth interactions. It's not uncommon for revisions or modifications to be needed to existing documentation throughout the years that a learner is in training. And it's important to clarify that does not mean that the original supports were inappropriate, but things just may change over time. So learners remaining proactive and engaged are going to ensure that the most appropriate and useful accommodations are in place to be as genuinely helpful to the individual as possible. Finally, when it comes to the process for accommodation requests, it's recommended to make sure you give a sense of the timeline from submission to decision to implementation.
We know from research that fear of bias and stigma are major reasons why people don't disclose a disability. Another big barrier is simply not knowing what will happen to their information once they do. That's why transparency around communication is so important. Disability policies should clearly explain how information about accommodations is shared, who's informed, what information is shared, and just as importantly, what isn't. How is that information managed at the program or institutional level? Policies should also spell out who's responsible for actually implementing accommodations. Residents shouldn't be left wondering who's supposed to make something happen once an accommodation is approved. And also, it's important to plan for when things don't go as expected. Policy should include contingency planning, clear instructions about what a resident or fellow should do if an approved accommodation isn't implemented appropriately, so that they're not left to troubleshoot on their own.
Thank you. That's such important advice. And I just want to, as we're kind of halfway through our slides, I just want to reiterate what was said earlier, that all of this will be sent to you in a follow-up email. It will be and is being recorded, and that the policy toolkit has all of this information so you can check back with that. But in addition to what everyone else has said, another really essential piece of any disability policy is having a clear grievance and appeal process. And these are actually legally required. So you want to make sure that your policy has this, or contains this. So residents and fellows should be able to really easily find information on how to raise a concern related to accommodations or their accommodation request process. That includes understanding what steps they must take to try and resolve an issue before engaging or moving to any sort of formal appeal. If an appeal is necessary, the policy should clearly explain the process for that appeal. How does that work? How should they initiate it? What the steps are? How long the process takes? This clarity really helps reduce anxiety and reinforce trust in the system. But I encourage everyone to do a double check on that for sure.
So one of the most common questions that residents and fellows ask is about documentation, specifically who sees it. A lack of transparency around documentation handling is a major reason that people hesitate to request accommodations. So policies need to be explicit about this. They should explain who has access to the information, supporting the accommodation, what safeguards are in place to protect privacy. And policy should also clearly state whether documentation is ever shared, and if so, under what circumstances and with whom. And finally, a quick but important point, using a general email address as the only point of contact can feel like sending a message into the void. There should be a clearly identified role that the residents and fellows can contact if they have questions or need help. That includes questions about disclosure, accommodation requests, or appeals. So knowing that there's a real person on the other end makes the process feel more approachable, and that alone can make a meaningful difference.
All right, so I'm going to spend a few minutes talking about disseminating or publicizing the disability policy. So one way to think about this awareness raising step is PMP, for places, moments, people. So for places, even the strongest policy can't help anyone if it's buried somewhere. So one way to think about it is that the policy should be hard to miss, not hard to find. The policy can be maintained online in a central location, which can also help ensure that online accessibility standards are met. But keep in mind that learners and faculty and applicants are going to look for this information in different ways at different times. So links to this central disability policy should also be available across multiple platforms. And that includes things like the programs or the institution's public-facing websites, so that across specialties, a prospective applicant could find this information. It also includes internal-facing resources like GME handbooks or newsletters. And then for moments, so we encourage you to communicate about disability policies at multiple time points. Example occasions could be, interview invitations, onboarding processes, orientation sessions, or any wellness-related programming. In general, these kinds of moments are vital opportunities to signal a commitment to supporting learners and to fostering an inclusive culture. And then the last piece of this dissemination puzzle is people. So, we obviously need to make sure that current and prospective learners are aware of the disability policy. But, it's also important to target the array of people that learners might look to for guidance. So, their attendings, their mentors, their chiefs, their program leaders. These might be the first people that a learner thinks to seek out if they had questions about, accessibility and accommodations. And so faculty also need to be familiar with the relevant policies and processes. And one way to achieve this is through faculty development programming. Especially the faculty development workshops that are already focused on professionalism and supportive learning environments. And I'll pass it to Dr. Meeks.
Thank you, Maggie. Okay, so this last part is near and dear to my heart. If you know me, you know this. I'll admit I'm a researcher. So yes, I am always thinking about the data that we collect. But for you, the data also serves a really important person or purpose, rather. It serves really important people too, but it's to identify opportunities for improvement. One of the things I'm always thinking about is the fact that we don't have QI processes for disability inclusion. And I don't know why, because we have it for everything else. But the data really helps institutions understand kind of what's working, where are there delays in the system, where are there gaps, and whether systems are actually serving learners the way they're intended to. One of the things that you might find if you collect data is that there are patterns of kind of different decision making for different groups of people. That would be something really important to know that you might not know if you were not collecting data. It also creates opportunities for learners to provide feedback, which is critical. You want to make sure that learners feel safe in the process, and it's important for this type of feedback to be anonymous. At the same time, any good data collection has to balance the usefulness or utility of the data with care for its people. And this means protecting privacy and minimizing any emotional or time burdens on your respondents, so in this case, your residents. Thanks, Morgan. And we recommend collecting data in 3 ways. So similar to what Maggie was saying about the different ways. First is disability demographics. Wherever institutional data is collected that already collects demographic information such as race, ethnicity, gender identity, disability status should be included in this. One of the most important reasons why is because it signals that disability identity is really important, that it matters, and again, it allows institutions to understand who is in their training environments. But importantly, responses should always be optional and include things like prefer not to answer or I don't know. For analysis, disability data can be grouped into broad categories such as physical, sensory, or mental health related disabilities to again start looking at trends to see if any particular type of learner with any particular type of disability doesn't have as much access, or perhaps even the systems that you have set up to determine accommodations may know less about a certain type of accommodation that's available for a certain category of disability. The second area is monitoring formal accommodation requests. So programs should track how many requests are made, the types of accommodations that people are requesting. For example, Maggie brought up schedule adjustments, but there's also things like assistive technology. And then you want to know how many of these accommodation requests have been approved. It's important to track things like time to decision, and decision to implementation. I've heard stories of people requesting accommodations that took 8 months to put into place. That's 8 months without having access to your training environment. Equally important are the mechanisms for learner feedback. As I said, it is critical to find out from the people utilizing this policy and this process what their experience is like. So surveys, exit interviews, particularly after training, when those power dynamics are reduced and everyone knows where they're going, these can provide really valuable insight into the experiences of your trainees and ways that you can improve your processes. We're always looking for ways to refine and improve processes over time. And through all of this, I just want to clarify that privacy really is central. Data should be analyzed and reported in ways, of course, that protect individual confidentiality while still allowing institutions to measure the kind of satisfaction, ensure that they're meeting ADA compliance measures, and identifying any disparate outcomes for specific groups.
Thank you, Lisa, and everyone. I just wanted to let you know that all of what you just heard is also in an article in the Journal of Graduate Medical Education that was published in December. So you can find a summary of this there as well. Wanted to go over just a little bit of a view. Your QR code here will take you to the Disability Hub. And within that, you'll see there are several components. One are current resources. We have literature and some modules and videos and podcasts that are listed. Then we have these toolkits, and this is the policy toolkit. We also will have a webinar on the UME to GME toolkit in a few weeks. And then there are several case studies. So there's a wealth of information there that you can access. We do also have, as I said, the future UME to GME toolkit that you can access. And we'll have the case studies as well coming up in a webinar. So with that, we're going to move into our Q&A portion of this. And I want to thank our panelists for sharing their perspectives and everyone for being engaged in this work. And want to have you submit your questions through the Q&A that we would be happy to answer those questions for you as you think about your journey and how you can implement this in your own organization. Oops. And
And I would
Sure.
say, don't be shy. We get a lot of feedback about our webinars, and one of the biggest pieces of feedback is there's not enough time for Q&A. So we were really committed. We're following a Macy. We were funded by Macy. Thank you very much to the Josiah Macy Jr. Foundation. But Macy has this very strict thing, if you ever attend any of their webinars, where you can do 30 minutes of content and 30 minutes of, you have to hold 30 minutes for Q&A. So we're really aligning with the Macy format today and really want your questions. You can ask anonymously, I think.
Mhm.
So feel free.
We have a statement that perhaps you want to react to, and it's a little bit more in the data space, Lisa, but anyone can respond. When collecting disability demographic data, I would also recommend stating clearly and honestly about how that data was used. Most disabled folks that I talk to are wary of questions from their employers or potential employers about their disability status, even if anonymous. It's helpful to know when the demographics are only used for reasons that will help us. And speaking of anonymous, when you collect feedback data about disability policy, it's rarely actually anonymous.
Yes. Thank you so much for sharing that thought, that kind of personal perspective. I agree with you 100%. I remember when NRMP started asking about disability identity and my email was blowing up. What is this for? And I think you can go a long way by being really transparent and saying how it will be used, how it won't be used. A big thing is that personal identifying information will never be used. It'll only be reported in aggregate. Um, yeah, I agree with you. And it is very difficult if you collect data at the program level to actually, you know, to say that something is going to be 100% anonymized because depending on the feedback you want to give, that might have identifying information in it. So it might be important to think about the training institutional or sponsoring institution broadly doing the feedback collection so that that can be even further de-identified and protected. But that's a really important point. Thank you so much for bringing it up.
Another question from Patricia Anderson. Do you know of any organizations that have already implemented these guidelines?
I can jump in there if you'd like.
Terrific.
Kelly Shaw. I am part of Graduate Medical Education's leadership team at Geisinger College of Health Sciences, and we were actually one of the 5 institutions to demo the policy toolkit as kind of to see how this was in action. And so I am happy to answer questions about our process, and you can also read about it in the JGME article that was referenced earlier about some of our experiences. And they tried to choose, from what I understand, tried to choose institutions of a variety of sizes and types to see what did this practically look like in practice, because it's not as straightforward. My sponsoring institution, DIO, says if you've seen one sponsoring institution, you've seen one sponsoring institution. And so the policy toolkit, which we found really helpful, provided guidance, but without being too prescriptive. And so I would say that the hub also has information on, and some of our vignettes, if I remember, Lisa, I was quickly trying to see on the hub if I could identify where those vignettes were, and I wasn't able to quickly enough grab that link, but I can try to find that. But yes, we do have institutions, Geisinger being one of them, that tried it out.
Yeah, I would add, as being at a big university that already had a lot of policies in place around disability, and also has a central office that manages disability requests for accommodations. And we actually have a team of people who do that for the university. They were very hesitant for the Graduate Medical Education Office to stand up our own policies. So what we did instead was really make access to policies much easier to find, and made sort of a flow sheet of how do you request accommodations, and sort of almost more normalizing it. And we had our Office of Institutional Equity come and speak at our Graduate Medical Education Committee meeting about how program directors can help their residents and fellows access the services of the Office of Institutional Equity. So just another way.
And I just want to point out that Kelly and Jessica were part of our committee, but also part of the example institutions who took this and operationalized it in their settings. And so you can read about that in the paper as well. There were 3 other institutions that did that. And we purposely chose people from different types of institutions. So you might imagine that people have varied levels of access to resources and staffing and kind of distributed models versus not. And so I encourage you to read that article that'll tell you a little bit more.
Terrific. I'm going to jump to a question in the chat. Do any institutions have a committee of physicians within GME to assist with accommodations? Individual programs may have little experience and not be aware of potential accommodations. At our institution, there's one HR person for the entire health system to approve or deny accommodations, and they have no medical experience, nor do they know the details of residency or fellowship jobs in each specialty. So collaboration question, who would like to take it?
We have a similar structure. I'll defer to Lisa, but I'll just say we have a very similar structure. One HR person for our, 27,000 person system with the whole range of job descriptions.
Yeah, I would say I can answer from the research policy perspective, and then I'd love for Maggie to answer from the kind of what does it mean to have I mean, at first when I thought committee of physicians, I almost had a visceral, I think I did have a visceral response to that. But, we have to consider things like ableism and how it permeates our environment. And so when you put groups of people together, oftentimes you wind up with bias being reinforced and concerns like that. But the actual legal process is meant to be interactive in nature, such that the HR person should be engaging with specialty specific leadership. So that could be the chair of a department, that could be the program director, to look very specifically at the learning outcomes, requirements, competencies of that residency with respect to the functional limitation without disclosing too much information about the diagnosis the learner carries. But that should be part of that. I certainly don't expect for someone who has a business or management degree to understand medicine at the same level and with the same level of specificity that a program director or associate program director is going to have. So certainly they should be informing that process. As someone who does a lot of work in policy, I get very concerned about the idea of committees for several reasons. But I could see how an institution might think that that's a reasonable mechanism for quickly and efficiently going through accommodation requests. But I would encourage you to follow kind of the interactive process, working individually with the HR person, or even having a training with the HR folks at your institution that kind of showcases and then codifies what is required, what's essential in that workplace. Max, do you have any?
Lisa,
Yeah.
Lisa, Dr. Behrens clarified in
Oh,
their
sorry.
question.
I saw that. I'll
And-
piggyback off of that.
Oh, okay.
Thank you,
Maggie,
Maggie.
did you take it?
Because I'll piggyback off of what Lisa shared, and then also with the clarification from the question and comment in the chat. So, I think I guess I'll share some additional insights from the interviews that I conducted with program leaders, which, a lot of institutions have different processes for, and sometimes the processes aren't totally spelled out or very clear for how a resident should, go through the process of disclosing a disability and seeking accommodations. I think there is this common theme of, program leaders not feeling like they necessarily have the expertise to determine what kind of accommodations are needed or necessary. And so it was, I think, just an important thing to have third-party input from an expert. This also gets at another question in the chat too about who should have, access or knowledge about the disability. And like in general, a program director shouldn't be the person that a resident like needs to disclose to. Um, and ideally, they also shouldn't be the arbiter of whether or not accommodations are needed. So third-party input is super important, and that in some institutions it's HR, other institutions it's occupational health. Sometimes they're, specialists or primary care doctors that can weigh in. I can speak from my experience receiving accommodations. It was, a mix of occupational health and then also input from various specialists that I was made to establish care with when I was going through my onboarding process. So, and this is something that also is like highlighted in the policy toolkit too, which is just the fact that like no one party has all of the information. You alluded to in the question and comment that HR doesn't necessarily know all of the ins and outs of GME. And so like, yes, HR can be an important piece of the puzzle, but then like GME and the learner and, other folks can weigh in too. And so I think maybe that's what you were getting at with this idea of a committee. And in that sense, yes, like we encourage that. And I hope that answers the question and the comments. And Lisa, that if that sort of maybe rounds out the perspective that you were sharing.
Perfect.
Slightly more specific question about higher ed in general is scrambling to meet federal requirements for digital accessibility. Do you have any sense as to where GME is regarding digital accessibility?
Oh gosh, no, I can't even imagine. This has been something that has been coming. So I think the deadline is just new, but the regulation is not. So yeah, I know that there's a lot of people out there hiring for people to make things accessible. I will say, and this is not going to help in knowing who is doing this well, because I don't know, but I will say that the design is so much easier if it's designed before things are placed onto the websites, if they're designed with access in mind. And I think ultimately it's less expensive also to have somebody at the institution who is making sure that content is accessible. And it improves learning for all of our trainees and access for everyone. So yeah, but I don't have any direct knowledge of any GME program that's doing this well. But I imagine a lot of people scrambling, both in UME and GME.
Sounds like more to come.
Yeah.
Uh, I There's a sort of a piggyback on the question we just had related to HR, a little more specific. And I think it gets to something, Kelly, you were touching on as well. And I'll read the question. We have had an issue at our institution working with HR around accommodations. Specifically, they often want a date of completion of treatment or end of date accommodation, or want really specific information on what will be provided. They're also not as familiar with medical training components, led to an informal accommodation process through the residency, which also has its drawbacks. How would you recommend trying to bridge that gap with HR? And I think, Kelly, you were raising this related to sometimes you have a request, but you would then have a long window and you try to create these informal accommodations. Any thoughts on that?
Yeah, and this was kind of a sidebar conversation I think we were having where a question that I get in my role as the director of well-being for GME and often in a position to support residents as they're starting residency, they have a sense that it's not going to be seen favorably. There is a lot of ableism within medical education, and so they're wondering how best to navigate this. They want to be proactive, apply through the formal process, which I strongly recommend that they not rely on kind of informal accommodations. And there is often a question, programs who are very well-meaning will say, well, what can we do in the interim? How do we make sure that things don't start to go downhill as that interactive process is taking place? And so I was actually going to throw it out to my panelists, to Maggie, to Lisa, to Jessica, to others to see what do you recommend that doesn't interrupt the formal process, but that does provide some of that informal. And I can share what we're trying to do, at Geisinger to offer that support without stepping on the toes of the formal process. But I'm also curious to hear from others on the panel what they're doing and what they recommend. And maybe this is the moment to call out Geisinger and say, hey, actually, no, which I share vulnerably just to say, like, hey, we're trying to figure this out. We're trying to do right by our residents and fellows. And this is kind of new territory. This is, Lisa, you've been doing this in the realm of the UME world for a lot longer, and GME is kind of the Wild West, the great frontier in terms of medical education. And so, I'm curious to hear what others say, and Maggie, what your experience is around that informal process in the interim while formal accommodations.
Sure. Yeah, I think it depends on the context and like the type of accommodation needed. But I think that the COVID pandemic was like a really good example of informal accommodations that were, happening like pretty large scale. So for instance, I have a lot of high risk autoimmune diseases that put me at high risk for severe COVID, and was in residency when the pandemic began. And so we didn't, we had limited testing, limited protocols, limited PPE, and all that stuff. And so like my program provided informal accommodations in some sense for people like me. And I think this has happened at a lot of programs, but like I was changed to a different rotation I was in the ICU, they put me on a different rotation. When I was, on my medicine rotation, if there were patients down in the emergency department who like had a respiratory illness, then my amazing co-residents like informally decided that they would see them instead of me. Again, we didn't have masks. So I think that's an example. The same kind of thing happens with, somebody has shingles and someone's pregnant. Like, then usually they stay outside the room and other team members see them. So that kind of thing happens informally a lot, for better or worse. But it also, I'm sure, like I said, depends on the type of accommodations. I don't know if others have anything to add.
Well, I would piggyback off of what you and Kelly said with the idea that when people are doing this, it's with the very best of intentions to support the learner. And I certainly don't want to discount the probably myriad physicians who are in practice right now because of the benefit of having an institutional sponsor, a person who really kind of helped them with the system, and when things weren't working, when systems and structures were not operating well, that they help them informally through the system. I think we all can appreciate that. I do, with the risk management lens, feel like as someone who sits as an expert on multiple cases, I have the other perspective of seeing learners who didn't disclose and request accommodations, who then have relied heavily on these informal processes and kind of, goodwill, if you will. And in those cases, when things go awry or relationships break down or the need becomes larger than the informal kind of provider of the accommodation is willing to provide, then the learner is really in a very, very difficult situation because they are actually not covered under the law. And there's a lot of nuance to that, right? They disclose to somebody at some point to get the informal accommodations. So I don't want to suggest that it's not muddy, but it's very clear that the learner has to engage in this process. So I would be concerned about the ultimate protections of the learner. I would also be concerned about the pressure that one faculty member might put onto other faculty members who don't share that confidence or privilege even perhaps. We all know that depending on how long you've been there and what your role is, there are different privileges in these organizations. So it puts a lot of pressure on other people to provide similar accommodations that they may not feel comfortable providing without some sort of guidance from the people who have been designated in the hospital system or the training system to kind of make the determination for this. So while I completely understand and appreciate and have so much um, empathy and just appreciation for people who have done this, I also, on the flip side, to balance it, have very serious concerns about this mechanism of like let's just get through or let's just try it and do this or that. I will say, seen learners not have their contracts renewed. I've seen learners dismissed from programs who could have been accommodated differently and with the protections that chose not to go that route and went an informal route. And it's always sad to me to see that occur when someone could have been better protected.
I just want to add one other thought. Right after match day, our GME office sends out a welcome letter to everyone who's just matched. And
Mhm.
it includes information about how to transfer your health care to our
Mhm.
institution, to our university health
Mm.
system. And it includes information about how to request accommodations. And as DIO, I worked with our Office of Institutional Equity to get them to say that they would, even those people weren't really employees yet, they were
Mhm.
willing to review their records and work with them and work with the program director to figure out how reasonable accommodations could be made, even
Yeah.
the proactively, so that July 1st didn't hit and all of a sudden now they agree to look at the records. We
Mhm.
have several months of lag time
Yeah.
between match day and July 1st. And we have decided to take advantage of that time. And it's worked actually quite well for us.
We
I,
And
established a
most
similar
importantly for our
process.
learners.
Yeah, that's
Pardon?
an excellent point. I just want to, for the people listening who have something to do with the process, you can provide temporary accommodations, still going through the process so that you're protecting learners while they're engaging in getting updates or whatever paperwork is needed. That is certainly within the purview of the institution.
I also
We
just
have,
wanted
sorry,
to
go
make a
ahead, Maggie.
quick note that it's I had a similar experience when I was on like after I matched it at Duke for residency. And it was an important part of helping me get set up with accommodations in a timely manner. But I also had my medical student health insurance. So everything was out of network when I was going through stuff. So it was actually very expensive. So just something for programs to keep in mind if there's a way to optimize that, advocate for it.
I
We
want
implemented something very
to,
similar to Jessica's process, where from match day on, we send out how to set up healthcare, be proactive about that. And then we also include a how to apply for disability accommodations. Our institution, you can't apply until you're officially an employee, but they can contact HR in advance. They can find out what that process is going to be like. And then we do say, and if you want to start the conversation with your program, we've designated two points of contact within our GME leadership team who are who are HR liaisons who can work with your program to identify what might this look like in the interim. And we reference this is informal interim accommodation. I don't know how many times we say that to just say, hey, you still need to follow the process as soon as you're eligible to initiate that process. But in the interim, here's what support we can provide from the GME office. And I'm happy to share those documents with anybody who wants to reach out to me individually, krshaw1@geisinger.edu. Again, my name is referenced in the JGME article, but happy to share our processes and what we're trying to do in the best faith effort to support our learners with that transition, because it's a big transition.
there are two questions I was going to try. And I think you touched on this one a little bit as you were talking, and this is Patricia Anderson asking about orgs that have tested this and we've described challenges, what were some of the qualities or characteristics that made success easier to reach? And it sounds like some of the strategies that each of you was just describing play into that. Anything else come to mind that leads to success in this area?
I will say from learners' perspectives, what you said, Jessica and Kelly, was the single most important thing that they noted. I know that Harvard Internal Medicine program does this as well because my two learners were going there, but it was that immediate, it was for the interview. So not just matching, it was for the interview to say, we recognize and value. So it was more flowery, supportive, encouraging language, but it was something like we recognize and value disability lived experience if you need any accommodations for your interview process. So even starting in the interview process, we send messages, right, with our language, what we choose to put in policies, what we choose to put in emails. And the absence of any language around disability, I would say, is also a form of communication about disability.
Yeah.
So that was from a student perspective, since we don't have a learner on this call, I will say that was the single most important thing for my learners that was really, really critical.
Educating our programs too on what their role is and is not. We recently held internally a panel with our HR representative, our GME HR person, with a program director who's currently actively going through the process, with a resident and myself. And that was a really useful thing. Like, hey, these are your roles. This is not your lane. Like, stay out of that lane. You don't have to be the one to decide that. That's why HR gets to be involved. This is the program director's role. This is the resident's role, et cetera. And trying to kind of clarify and give people permission to stay in their lane and not have to be the judge, the jury, the advocate. Like, there are roles for advocates, and that's one of my roles. There are roles for the residents, roles for the PDs, and it's that group that comes together to figure out what does this look like to support the learner with the goal of getting through their education.
Great. One other quick question, and that was, do we see any patterns around specialties that participate more or less in active disability policies?
I don't think it's really fair to remark on that because I think it's so specific. First of all, I think disability work in general is driven by people that are in the institution, right, with lived experience or familial experience. And so I think you see these pockets of things, and then it's who's doing the research. So there could be people doing very, very, very good work. They're just not publishing it. So if you look at Maggie and I and our scholarship, you'll see peds and internal medicine. And that might falsely lead you to believe that peds and internal medicine are among the most, accepting, inclusive specialties, which maybe, but I know surgery specialties that are incredibly inclusive and, OBGYN specific residency programs that are especially inclusive. So I I wouldn't want to suggest a pattern because I think it might preemptively keep learners from looking at specialties that they love in favor of specialties where they think they'll feel safe. And I wouldn't say that you would be safe in necessarily any specialty, depending on where you matched.
Great response. And we are heading into the top of the
Right.
hour, so I'm going to cut you off a little bit there. And I saw one last question about affinity groups or organizations, and I encourage people to go to the toolkits. There are lists to links as well as on the Docs with Disabilities website. And we will have another webinar on the UME to GME toolkit March 31st at 4 p.m. Thank you, everyone, for joining us today.
Bye.
Thank you.